ladies and gentlemen, those physically present with us here and those online, thank you for honoring our invite to this dissemination meeting today. My name is Melody Kukundakwe, the Communications Officer for PMA Uganda. I'll be your moderator for that day, alongside Ms. Harriet Adong from the Resilient Africa Network. I would request all of us to stand up for an opening prayer, and thereafter we'll have the anthems to honor our country, East Africa, and Makerere University.
Thank you, Melody. Let's humble ourselves for a word of prayer. Lord, we thank you for the gift of life. We thank you for today. We thank you for keeping us up to now. We thank you that we are together this morning. We thank you for PMA, for the School of Public Health, for Makerere University, and all our implementing partners. We pray that you come amidst us as we deliberate. May it be for the greater glory of your name, but also for the greater glory of our institutions, the country at large, and the globe. I pray, Father, that you guide our discussions, that all might go successfully. I pray all this with thanksgiving, believing in Jesus Christ our Lord. Amen.
Oh, Uganda, may God uphold thee. We lay our future in thy hand. United, free, for liberty, together we'll always stand.
Twaomba uilinde Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Uzalendo pia mshikamano viwe msingi wa umoja wetu, na tulinde uhuru na amani, mila zetu na desturi zetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Viwandani na hata mashambani, tufanye kazi sote kwa makini, tujitoe kwa hali na mali, tuijenge jumuiya bora. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Makerere, we build for the future, the great Makerere. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. From east and west, from north and south, all voices singing, arise, Makerere. Rise up and rise, high up and high, all voices singing, walls around thee. Great, great and mighty the gates beside thee. Great, great and mighty the walls around thee. Great, great and mighty the gates beside thee. Do not forget through all the years those who have gone through the gates of Makerere. Give them the pride, give them the joy, all to remember the gates of Makerere. Makerere, Makerere, we build for the future the great Makerere. Great, great and mighty the walls around thee. Great, great and mighty the gates beside thee. Great, great and mighty the walls around thee. Great, great and mighty the gates beside thee. Those who may be, seek ye the truth, build for the future the great Makerere. Those who have been, those who will be, build for the future the great Makerere. Makerere, Makerere, we build for the future the great Makerere. Great, great and mighty the walls around thee. Great, great and mighty the gates beside thee. Great, great and mighty the walls around thee. Great, great and mighty the gates beside thee.
In a special way, I want to recognize our donors, the Bill and Melinda Gates Foundation and the Children's Investment Fund Foundation. I would also like to recognize our project management unit, Jhpiego, and our technical unit, the Johns Hopkins University, all Ministry of Health, and all implementing partners. I'll now request Ms. Harriet Adong, our co-moderator, to welcome our chairperson for today.
Thank you, Melody. I thought Melody deserved a hand clap. Is it because we've had breakfast? Thank you. Ladies and gentlemen, allow me to welcome our chairperson for the session. And briefly, he's one of us. He's Dr. Mugahi Richard, who is our Assistant Commissioner for Reproductive and Infant Health at the Ministry of Health in Uganda. He was formerly a district health officer for more than 10 years and also worked as a health service provider at different levels of healthcare. Dr. Mugahi is currently a member of the National Safe Motherhood Committee, and he has also worked as a board member of the National Medical Stores here in Uganda. Most importantly, least but not last, Dr. Mugahi is also a vasectomy champion in the country and globally. And in addition to that, he whispered to us that he's a husband to one wife and a father to very few children. He said, usually you don't count children for a man. So join me to welcome our chairperson, Dr. Mugahi, to take us through the session this morning. Over to you, Doctor. Thank you.
Thank you so much, Harriet, for that very humbling introduction. My role really is to chair this very important function, and I would like to draw your attention to our program. The program sheet is right in your booklets, and I was just consulting, but allow me, before we go to the program, to recognize the presence of a few personalities amidst us. And if we had a second mic, it would be really appropriate for them to introduce themselves. These are very big people. In a special way, I would like to recognize our honorable members of parliament present here with us. If there's no extra mic, I think we shall do that later. I'm just careful not to miss out some, but I can see Eble, the chairperson of the Health Committee of Parliament, Honorable Charles Ayume. Thank you so much for coming. He's always been with us. Dr. Kamara. Dr. Kamara is a physician and also a vasectomy champion. I saw him waving at me when they talked about vasectomy. Dr. Kamara, thanks so much for coming. Honorable Sylvia, thank you so much for coming. She has been with us all through. The Vice Chair of the Health Committee of Parliament, I've seen him behind there. Thank you so much for coming, Honorable. I think my friend and colleague Francis and Charles will help me recognize the other members of Parliament. They could be within here, but may not be able to. Can we get a mic and they introduce themselves? I don't want to make mistakes very early in the morning. And sanitizer. Briefly, the members of Parliament, we appreciate your presence. Would like you to introduce yourself. I managed to introduce those who I could see.
Okay. Thank you very much, Chair, and all members present. I'm called Sylvia Bahireira Tumwekwase, a member of the Health Committee, and I represent the people of Kamwenge District in Parliament. Thank you.
Good morning, colleagues. I'm Dr. Nicholas Kamara. I'm a consultant physician, but I'm also a member of Parliament for Kavali Municipality, member of Health Committee, and chairman of Parliamentary Forum on Non-Communicable Diseases. Thank you.
Good morning, colleagues. My name is Dr. Charles Ayume, member of Parliament, Koboko Municipality, and the chairman of the Parliamentary Committee on Health. Thank you.
Chair.
This is, Dr. Mwonge, where you are seated there, I think you can become a member of Parliament by infusion.
Thank you, Chair. Good morning, members. I'm Sebikali Joel, MP, Twetwe constituency, Chankwanzi District, and I'm the Deputy Chairperson, Health Committee, Parliament.
Thank you so much. Catherine, you can wave at us, and you've done a great job. You always help us. Catherine works with Parliament, and she always helps us. And Susan, I think. And Lydia. Lydian, yeah, that's good enough. So that's the group from Parliament that we have with us. I also want to recognize the group from Makerere. Let's now recognize in form of groups, and we move. Group from Makerere, I think you wave for us, you wave at us. Most of you shall be seeing you. Honorable is again in another group of Makerere. The group from Ministry of Health, I can see Commissioner Penso, Commissioner for Community Health Services, and myself, Rogers, and the team. Thank you, Ministry of Health. Our partners, implementing partners, USID, I can see Rita, I can see PATH. Implementing partners wait for us. Thank you so much. Religious leaders, implementing partners don't want to show themselves, but we are going to give you assignments in this meeting. Religious leaders, there is no pastor. You are the only one who doubles, triples. He's also a pastor. Thank you, Honorable. If there's any other category, the media, you're very important in family planning. NPC. And on that note, allow me also recognize my former chair at the National Medical Stores Board, who is also the director of NPC, Dr. Josam Musinguzi. He's part of the agenda today. Dr. Josam, you're most welcome. And thank you for having been the brain behind most of the family planning reforms in this country. Colleagues, that marks the end of the introductions. If there is a special group that I have missed out, Prof. Makumbi, have I missed out a special group? I guess no. Oh, our online, our virtual attendees, Dr. Laro Charles, Director, Curative Services, Ministry of Health. You're most welcome, and you'll make some remarks. Professor Roda, the Dean, Makerere University School of Public Health, you're most welcome, and we're expecting your remarks very shortly. Friends, allow me at this time to invite Professor Roda Wanyenza to make remarks on behalf of Makerere University, and then that will be followed by Dr. Charles Solaro. Professor Roda, you're most welcome. We missed your physical presence.
Thank you, Dr. Mugebi. I have missed you all as well, and but I'm still excited to connect with you all online. Our members of parliament, the chairperson for the PMA Technical Advisory Group, Dr. Musinguzi, implementing partners, our religious leaders who are present here with us, colleagues from academia, the PMA team, the media, ladies and gentlemen, all of you in your respective capacities, a good morning. It's a great pleasure for me to connect with you this morning. As always, we look forward to engaging with you and to sharing with you what we do at the School of Public Health, because we believe that if we don't share with you and if we don't take decisions based on the evidence that we generate, then our research is not of any use. Because we know that the primary reason why we generate this evidence is so that you can know where we are with our policies, with our programs, so that you can know where the challenges are. Who is it that we are leaving behind? We are now in the era where we believe that we are as strong as the weakest link around us, and that the more we are able to bring everybody else on board, the better we are, all of us together. So a lot of the work that we do is geared towards showing where we are, but especially showing who we are leaving behind so that we can do better to bring everybody on board. And the PMA program is just one of those flagship programs at the School of Public Health, where we generate evidence and continuously engage with all of you so that together we can decide what more we can do to better serve our people, because we don't improve programs for the sake of it. We don't make policies for the sake of it. We do that so that we can better serve our people, and that's what we desire to see. And this program shows this especially because all the data that we have generated has been used by all of you stakeholders here with us today. For example, we've just used the PMA data to inform Uganda's FP 2030 commitments. And before that, we were also looking at this data when we were developing the costed implementation plan. And for partners in the room, implementing partners, those that are coming from outside Kampala, this data is also available to inform the regional plans as you think about how we can better focus our interventions at regional level to better serve people, because we note that sometimes we are doing well overall, but we are leaving some regions behind. So this is just an example of what we do at the School of Public Health. We have a lot of programs that are also doing research with family planning, but also many other health programs. And increasingly, we are now looking at determinants of health. Now that we have a lot of our legislators in the room, I don't want to lose the opportunity to say that we are not going to improve health when we only look at the health sector. We have to be looking at the determinants of health holistically if we are going to improve health and well-being for our people. Issues to do with education, issues to do with livelihood. We are talking about people just having income so that they can live a better life. All these issues are very critical in terms of meeting our health needs and getting to make sure that our people are healthier. Let's focus on this. And this is even a more critical time because COVID has shattered the determinants of health. And in fact, some of us are very worried from public health because we have been through a situation where we have had to choose between life and livelihood. And when we don't have livelihood, we don't have life, we don't have health. So we need to rethink how we are going to reorient our public health systems in a holistic way, looking at all sectors and determinants of health. And I would like to especially draw your attention to education. I know you're members of the health committee, but you need to engage with the education committee as well, because we have so severely disrupted education that is going to hurt health for many years to come if we don't act today. And then we also need to be reorienting our health to look more at promotion of health and prevention of disease. Please don't focus at only treating people who are sick. So to our members of parliament, please look at these issues holistically, and we are available to engage with you more if you can give us space so that together we can chat away in terms of how to improve the health of Ugandans in a holistic way. So with this, I would like to say that together we can also generate more evidence. You can tell us where is it that you need more evidence that you don't have, so that we can work together to generate this evidence. Now I know today is for family planning, so that's enough of the other public health, but I wanted to say that we are available and we are ready to work with you so that you can make more evidence-based interventions. To this occasion, I would like to thank all the partners that have worked with us for a very long time to make this work possible. We have worked for a long time with our partners from the Population Council. We thank you so much, Dr. Msinguzi and your team, Dr. Charles Solara and colleagues from the Ministry of Health. Thank you so much for continuing to work with us. The School of Public Health, Jhpiego, the Uganda Bureau of Statistics, thank you so much for continuing to work with us on many surveys that we do in this country. But I also need to appreciate our teams. Dr. Makumbi, Dr. Simon Chibira and your team, thank you so much for continuously delivering high quality work with support from our colleagues and partners from the Bill and Melinda Gates Foundation, the Children's Investment Fund Foundation. Thank you so much for partnering with the School of Public Health, not only in this particular survey, but also in many other projects that we jointly implement together. And as we celebrate 100 years of Makerere University, on behalf of the university, I would like to pledge that we will continue to generate evidence that adds value and that we shall not be in the ivory tower, as many people always ask us to do. You can see that for us at the School of Public Health, we are not in the ivory tower, although some of us are speaking off Zoom. We are with you most of the time, and we value our interaction with you. So thank you so much, all of you, for taking your time to join us this morning. And I hope you will enjoy your stay with us. I hope you leave, most importantly, with something that can add value to the work that you do to serve Ugandans, whether you're in Parliament, whether you're in the Population Council, in the Ministry of Health, implementing partners. Please do listen in and find something that can add value to the work you do so that we can better serve our people. Thank you so much.
Thank you, Professor Rhoda, and that clap is for you. We really appreciate your comments, especially the call for evidence-based interventions and the availability of the ivory tower to keep producing this evidence whenever we need it. We also appreciate your comment on the partnership with education given the fact that the determinants of health, some of them are housed in education, others are housed in agriculture, and we need a total rethink of our post-pandemic public health interventions. Thank you so much, and we really appreciate all the great work that you continue to do for us. At this time, I want to report that our Director for Curative Services, Dr. Charles Olwaro, transitioned from virtual mode to physical mode. It must have been by God's grace. Miracles still happened. So Dr. Charles Olwaro, my old friend, we've known each other from a long time ago. We worked together in Fort Portal. Now we are together. He's my boss at the Ministry of Health. He's been a very great champion of family planning, reproductive health. He's also the chair of the National Experts Committee on Safe Motherhood. And he continues to support, like Rhoda mentioned, and he has managed to make it this morning. He has opening remarks to make. Dr. Charles Olwaro, kindly step forward and make your comments. Join me in welcoming him.
Good morning. The chair of the Health Committee, Dr. Charles Ayume, and the members of the Health Committee of Parliament, the Dean of Makerere University School of Public Health, Professor Rhoda Wanyensi, my chair of PMA Technical Advisory Group, Dr. Joseph Musingusi, implementing partners, religious leaders, the academia, the PMA team, the media, ladies and gentlemen. As the chair has indicated, our transition, now I'm here physically. I thought I would have been here much more early. My apologies for that. But also, as Professor has indicated, this is what technology allows us to do, so that you have no excuse that you cannot be able to join. So this morning, as a Minister of Health, this engagement is very important for us and very dear for us, that it forms another fulfilling one as we come together to share the National Performance Monitoring for Action Survey 2021 survey results. As you will hear, you will agree that this is very helpful and very useful for Makerere University School of Public Health to conduct National Performance Monitoring for Action, the PMA surveys. We are grateful to Makerere because it's been able to contribute and be able to do this work. Otherwise, probably would be hiring a consultant to do that. So this is an inbuilt in-country capacity, and we're grateful for that. The data collected in these PMA surveys inform monitoring and assessing progress of the targets as we set in the FP 2030 commitments and the costed implementation plan. I'm happy that all of you were involved during the formulation and official launch of this commitment. I'm also happy to mention here that I sit in the FP20 Global Committee, and as you know, this is great for both, not only for our country, but for the region. From the last PMA survey, we have seen the country is making progress. However slow it is towards increased modern contraceptive use. We have been able to monitor this new mode of delivery of Depo-Provera through the substance injection, Cyanopres, that has become very popular in the last three years. And as all of you know, the FP 2030 commitments were launched, so we need to be able to work. We'll soon be able to share with you also the costed implementation plan, which is really a precursor for us to be able to achieve our FP 2020.
We are now serving number.
I will work with my teams because I would have really wanted that each of the members in this room would have a pocket, a small pamphlet, which is really highlighting the 6 commitments which as a country have made, but also picking up So Richard, I think this is some of the things which we need to be able to do what? So that members keep reminded of these commitments because they are very difficult to learn. However, there are challenges, much as we have made progress in family planning delivery, there are still some unresolved challenges. For example, the PMA has shown over time that there are challenges with the quality of family planning services, especially regarding the counseling of users. And if you go to our commitments, actually one of the commitments is actually dedicated to address this specific challenge, to address family planning myths and misconceptions. And so government is committed to improve the quality of family planning counseling. And in counseling, definitely we provide what are the available options, the possible side effects, because we have to be true to it, there are some side effects, but how do we manage them, their management, and how does the user switch on the different components? So we think that if we shall be able, though it's a challenge, but with the implementation of the commitment, and if we're able to measure it well, we should be able to overcome it. So what's new in this dissemination? This year we have results on self-injection for subcutaneous injections. As you all know that when COVID came, we really tried to look at what are those innovation approaches which people can be able to use. And I must say that if girls were able to access the self-injections, then you could be able to prevent very many of the unwanted pregnancies. Because just to remind you, 4 out of 10 mothers who are pregnant did not intend to have those. So they are really kind of like unwanted pregnancies. Though they have no alternative to carry them up to the end, but they would have wanted to defer them to certain appropriate time. The year survey also helps to gauge the effects the COVID restrictions may have had on the contraceptives. So we'll be able to see that probably would have been at a different level, but COVID came in. Though we might not put all the excuses on COVID, but what was the effect of COVID on that? So I want to conclude by some free take-home messages that the current challenges in this area of study and discussion require a concerted effort of Ministry of Health working with all of us in this room and even outside. And I hope the chair will, and the members, first of all, your attendance here is already sure that you have the commitment to be able to work with us in this aspect. We need to develop, adopt, and use innovative strategies to inform programming in an effort to address some, if not most, of these challenges. And I want to implore all of us to continue implementing what works based on the findings and creatively work to address the challenges that the surveys help us to unearth. So I would like to thank Makerere University School of Public Health, the Uganda Bureau of Statistics. I hope they are represented here. My colleagues at the Ministry of Health, all partners for this effort. I also want to thank the local as well as international partners, the Bill Melinda Gates Institute of Population and Reproductive Health at the Johns Hopkins University, and Jhpiego for collaboratively working and supporting the generation of this data. And I think they deserve a clap. So Adong, as the communication officer, you'll communicate that we clap to appreciate all what they have said. So lastly, again, these statistics that guide in programming for family planning in this country. So we really need to be able to see that at every point in time we should be able to gauge where we moved. We should not wait for the end of, by 2030, we should be able to see what is that we're able to achieve at the end of 2022, and progressively we should be able to look at that. We are all looking forward to a continued good working relationship as we strive for a better lives for our communities in which we serve and we live, for God and my country. Thank you for listening. I don't know whether I heard properly when the chair mentioned that I was supposed to open. So I think at the end of those remarks, the meeting is officially open. Thank you very much.
Thank you. Thank you. Another big round of applause, Dr. Charles Solaro. Thank you so much. I had left out one of your titles. I thought you would mention it yourself. Dr. Charles Solaro is the focal point person for Uganda at the FP 2030 platform. I think they sit in Washington. Join me in thanking him for representing this country ably. I don't like paraphrasing some remarks, but he was very explicit in mentioning that we need to translate evidence into practice and policy, and we must implement what works. In the family planning arena, we all know we have the high impact practices. So that is probably what is awaiting us in the general remarks. Once again, thank you so much, Dr. Charles Solaro. Your request on the 6 pillars for the 6 points for the family planning commitments, even before we leave here, I think we should be able to print and each one of us goes away with them. That's very important about our strategic direction. According to the program, we now receive remarks from Uganda Bureau of Statistics, but I have requested my friend, Dr. Charles Sayume, to also make remarks on behalf of that constituency that is amidst us. Brief remarks, I know it's an ambush, but as a health professional, I know you'll have some comments about family planning. Some of you may not keep here till the end, but if we would hear from you, it would be very nice, our honorables. So Mr. Chris Mukizi is not here with us, but I would also like to welcome Mr. James Muwonge, who is representing Dr. Chris Mukiza from the Uganda Bureau of Statistics, to step forward and make his remarks. We are doing quite well. All the speakers have kept time. You're welcome. Join me in welcoming Mr. James Muwonge to make remarks.
Thank you, Chair. Honorable members of Parliament, Dr. Musinguzi, my Chair, implementing partners, colleagues, ladies and gentlemen, good morning. On behalf of the Bureau of Statistics, I would like to congratulate the School of Public Health, Professor Makumbi and team, for pulling this off again. I think there have been several surveys that have been undertaken. And to us as a Bureau, we've been working closely. And having consistent data for so many years is not a very common feature in many agencies. And to us, this is a clear testimony that the kind of competencies and skills in survey implementation are at the levels of best practices. So I just want to thank you. I think this is an area which initially started at a low level, but now when I look at the audience and the participants in this room, it really demonstrates the kind of attraction it has received and the importance you attach to the kind of information that is coming through. Of recent, it's not only looking at cross-sectional, but now they're even going further to even follow others who were interviewed previously. So paneling and looking at the dynamics is another feature that this team has brought on board, which is quite important, and it will be able to provide you with even much more insights into what drives some of the behaviors that you're about to see. As a Bureau, of course, we can't collect all the information, but agencies and institutions, research institutions, continue to collect this information. But what we always want to encourage is to work together so that we can consistently share information and share best practices. I think the key thing here is coordinating our efforts, research efforts, across the different agencies and make sure that we are able to share information. I think the Dean of Makerere has talked about it, the need to utilize information. There's a lot of information that has been collected, but probably not so much is being used. But I'm at least looking at the audience here, I'm encouraged, and I feel a bit contented that the level of utilization is getting as far as the parliament. And to me, this is quite important because information should influence policy and decision making. And the fact that in this audience, we have those policy makers, to me, it's a testimony that the value coming out of this survey is really quite important. So I would like to thank you once again, and they promise that as a bureau, we'll continue working together, and probably also encourage you beyond family planning. You could also explore other areas so that the expertise you have acquired in implementing these surveys also extend to other areas of disciplines so that the best practices, not only limited to this one, but also we see and get more information to inform policies, not only in Ministry of Health, but also in other areas. Because as they say, you see, health, there are so many other factors that contribute to health. So we need to look beyond health and also cover family planning is one, but there are other areas. So where data is still, there is a data gap. So we need to keep on closing these data gaps so that our policymakers are well informed with what needs to be done, and they are equipped with evidence that we should be able to provide as a bureau, but also as the School of Public Health. So ladies and gentlemen, I just want to thank you and wish you good deliberations. I thank you.
Thank you so much once again, Ubos, for joining us this morning and for the words of commitment to continue working with us, and the challenge of us going beyond. I think that's Professor Makumbi. Can you go beyond family planning? And I think you are ready for that challenge. As I earlier mentioned, I've been briefed that in your folder there is a mask, and I think Harriet wanted us to be uniform. I don't know. She wanted us to be homogeneous for branding purposes. So, but you can remain heterogeneous. I think it's acceptable. But there is a mask for you in your pack, and it's branded PMA. The P is performance, M is monitoring, and A is action. It actually ushers us to the next session of this meeting, where Professor Makumbi and Dr. Simon Chibira are in charge of PM, performance monitoring. Myself, Dr. Olaro, and other stakeholders for action. In Uganda, there is a tendency of choosing what we want to do. We can do performance monitoring and forget action. We have been engaged in the national MPDSR, so we usually say that the R is neglected, maternal and perinatal death review and response. So we don't do much of the response. We review and we forget to respond. So I don't want a scenario in PMA where we do performance monitoring and we forget action. And for this specific meeting, Dr. Betty Chadondo will synthesize the action bit. I've been briefed that he will take us through the A. Professor Makumbi and Dr. Simon will take us through the PM, performance monitoring. And I'm very informed this is not the first time, it's not going to be the last. So they will always give us the performance monitoring, how we are doing, and how we use this is actually what measures our success. So I had earlier mentioned that I would kindly allow Dr. Charles Ayume to make some remarks. I've ambushed him, but I know he's good enough. The reason is really for constituency representation. They're usually busy people. They may not be with us till the end, but if you can make some remarks and listen in, we will be very happy to engage you in the discussion. Dr. Charles, you're welcome. Join me in welcoming him as he makes his welcome.
Thank you very much, Dr. Mugahi, and the very pleasant ambush, but we are always prepared for any eventualities. My colleagues from Parliament, especially from the Health Committee of Parliament, the Director of Clinical Services, Dr. Olaro, the various health partners with us in the room, members from Makerere University, led by Professor Makumbi and Dr. Jhpiego, who are also, I'm also a student. I hope these are not my political opponents. Trying to sabotage a wonderful speech. Yes, I was just saying I'm incidentally a student at Makerere University, so no doubt about the competence of the team led by Professor Makumbi. Ladies and gentlemen, you're most welcome, and mine is very simple. We are very happy as the Parliamentary Committee on Health to always be invited for these engagements. It really sharpens the way we articulate issues in Parliament. And I must say, we really want a Parliament that articulates issues based on evidence and very strong data, not one where we go and debate based on emotions and political sentiments. I think that is very dangerous for the direction of the country, where we are on the floor of Parliament just arguing and debating based on emotions and retrospective beliefs. So for us, it's very important that we're invited for such engagements where we come to listen to evidence and data, what's in the field and what are the best practices, so that when we go there, because we do not only represent our constituencies, our political constituencies. The health sector, like I keep on telling many people, is a constituency. So I have one foot in my political constituency, but I am also duty bound to represent the views of the health workers on the floor of Parliament. And good enough, I have other health workers here. Honorable Bahirera, she didn't tell you, she was worked in Kamwenge district and the Rwenzori area for a long time. She's a midwife. We have Dr. Kamara, he's a consultant from Kabale. We have Grania, she's a laboratory technologist, woman member of Parliament of Mubende, and so many other health workers on the committee. And of course, my vice, we are about to also bestow him the title Dr. Sevikali, because he has been there for a long time and he understands the sector. So we are very humbled, and we shall continue coming to listen to words of wisdom whenever we're invited, so that we can translate this, because this is where data is produced, but then policy, fortunately or unfortunately, is discussed on the floor of Parliament. So if you do not arm us well, then we do a poor job on the floor. So thank you very much for having us over, and we pledge total support where possible. Thank you.
Thank you so much, Dr. Charles Sayume, for those wonderful remarks. I think we would have missed them. Ladies and gentlemen, we are done with the component of remarks. I think we are now going for the muscle. And in that session, we are going to be led by Dr. Simon Chibira. I have known Simon for some time. He's a very committed academician. He's been taking us through this PMA. We've done a lot of good work in this. Simon is going to take us through the PMA 2021 survey, background and methodology. And kindly put your hands together to welcome Simon. Dr. Simon to make his presentation. Simon, you're welcome.
Thank you, Chair. Allow me to take this off because I'm going to speak for a while. Good morning, ladies and gentlemen. Thank you for the kind introduction, Chair. So I'm going to take you through part of the methodology and then part of the results, and then Professor Makumbi will take you through the other half of the results. This survey is conducted, as you've seen, by Makerere University School of Public Health, together with the Ministry of Health and the Johns Hopkins University School of Public Health, the Gates Institute for Population and Reproductive Health at the Johns Hopkins, and Jhpiego, both in Baltimore and Uganda, and Mr. Ndifuna is here today. So we have a lot of support from Jhpiego in the country office, who have the program management unit here in the country. So quickly, slides. Okay. So this is the outline of the presentation today. We'll take you through the implementation of the 2021 survey. We've been conducting this since 2014. So this will be like the 9th time we are conducting this survey. And we'll take you through the findings from the household and the female survey part, and then the service delivery points survey. And also we have a special component, as you heard from Dr. Ralo in the morning. We are going to present to you a bit of patterns of DMPA-SC, or subcutaneous and self-injection that is associated with it today, because these were financed specifically by the Children's Investment Fund Foundation to try and monitor this, the training and also the continued scale-up of this. As of background, I've already introduced this, but this is conducted together with the Bureau of Statistics and the Ministry of Health, and the Bill and Melinda Gates Institute for Population and Reproductive Health. And the funding, we've always had funding from the Bill and Melinda Gates Foundation, but today, this year's survey, we also have funding from the Children's Investment Fund Foundation, as I have introduced already. We want to start with acknowledgement. Usually people end with this. We want to start with this, very important. And we want to start with the population that provide this data, the household data. The respondents are the household heads, both male and female, and then the women who respond to the individual questionnaire, which we use to obtain all this data. We also have health facility in charges and people at the different points within the larger facilities like hospitals, because we interview people from different areas within the hospital. So those, we also thank them very, very much. And of course, at the smaller SDPs like drug shops in the communities, those are usually one provider. We also interview those. We thank them very much. The team is led by a technical advisory group from the, led by National Population Council Director General. And then all of you as implementing partners here, the media, thank you so much. And very importantly, when we go to the districts, we have entry from the district health offices and the whole leadership up to down to the local council level. And then we have a wonderful large team of interviewers, about 140 of them, 20 supervisors and about 15 quality control officers that support this enormous data and whose faces you don't see always. You see our faces, but there's a large team behind this data. So thank you so much. This is just a pictorial representation of how the structure is, the technical team within Uganda, and the support. I've already introduced Jhpiego in the country and in Baltimore, and the Johns Hopkins University in Baltimore, and the technical advisory group that guides us as we provide the technical support in terms of questionnaire design, support to add what components are needed, and then the central team here, and a large team of research assistants here whose photos can't fit here, and the supervisors, but very large team that conducts these surveys. This is our technical advisory group, led by Dr. Jotham Musinguzi, as we introduced. The three of us provide secretariat, Mr. Pascal Linga from Jhpiego, and then the rest of the partners, some of whom, all of them are here today. Dr. John Sekamate, I saw him, Professor Roda Wanyenze online, Dr. Charles Oralo, Rosalind Achiola, Miss, and then Dr. Richard Mugahi, the chair today. We also, this technical advisor group co-ops technical members from the Bureau of Statistics. We have Mr. Mwonge, we have Madame Helen, who were in the last technical advisory group. So the objectives of the survey, we always do this, we've been doing this annually. So we do measure and monitor key family planning indicators on an annual basis. And we also do client satisfaction surveys at the exit of the facilities, which provide the services to the enumeration areas that we go to. And also we monitor family planning commodity stocks, stock in, stock out, availability at the service delivery points, both the public and the private. Today we shall be presenting results mainly from the public sector on that. So in terms of design, the 2021 survey design and its implementation, we went back to 122 enumeration areas. If those who were here last year, and we remember we had 122 enumeration areas, if you do remember, we have added 19 enumeration areas specifically financed by the Children's Investment Fund Foundation, and these are sampled by the Uganda Bureau of Statistics, and that is the big technical support we have from the Uganda Bureau of Statistics to conduct this together. And within there, we sample 35 households, and then we do surveys with women who are eligible 15 to 49 years in those households. And I said we go to the different service delivery points that serve the enumeration areas where PMA goes at the national level. So this SDP sample may be nationally representative, but it's tagged to the enumeration areas where we collect the data from. We do sample randomly 3 in an enumeration area for the private facilities. If they are less than 3, we do all. If they are 3 and less, we do all. If they are more than 3, we sample only 3. But we do all the public facilities that serve those enumeration areas up to the regional referral hospital through the referral system, guided by the district health officers in the districts. And we do conduct client exit interviews in the facilities that serve the enumeration areas who serve 3 or more clients in a single day. We do surveys on 2 consecutive days for all the women that turn up at the facilities if they consent to be surveyed. This year we want to show you a pictorial or a map geographical representation of where our 141 enumeration areas are. These are GPS coordinates of households in the enumeration areas. So the bubbles may be more than 141, although we show that this is 141 enumeration areas. Those bubbles are households in the enumeration areas. So they will be larger depending on where you are in terms of number of enumeration areas. So you see that they are spread out across the country, and Kampala has so many there because Kampala is treated as a region on its own. So that's why you see a lot of concentration of enumeration areas there, but it's similar to other regions when we break them out of the 15 sub-regions in the country. Again, this is done by the Uganda Bureau of Statistics, and we are so grateful for that. These are our survey response rates that we had this time around. We've always had very high response rates, above 96%. Today we have about 96% for the household and the women in survey, and we have about 93% for the service delivery point survey. This has dropped a little bit from about 96 that it was last year, maybe a little bit of fatigue, understandably, but that's what we have now. So, ladies and gentlemen, what are the main findings from this survey? I'll start with a key indicator. Over the last few years, we've been presenting results for the CPR, or the contraceptive prevalence rate for married women, the proportion of married women currently using a method of family planning. This year, I want to present 2 indicators. One, for all women. That's a more conservative indicator. It includes all women, married, unmarried, sexual active or not. So it's a more conservative indicator. The reason we are tracking this out this year is because when you look at the costed implementation plan 2, the focus is on all women. So the indicator is for all women. We don't want to leave anyone behind. You heard Professor Roda speaking about equity. You don't want to leave anyone behind, so we don't want to focus on married women alone because they all have their needs. So today we want to present to you the CPR for all women, the proportion or percentage of women who are using a method of family planning who are aged between 15 to 49. And the CPR in this survey is 40%. So 40% of all women are using a method of family planning. And 34% are using a modern method of family planning at the time when we did this survey in September, between September and November of last year. And the traditional methods are standing at 5.9%. And when you see, we've just picked out only 4 survey rounds. We have so many survey rounds before, but we picked the most recent 4. And you see the trend that we've been rising for all women from 34.7 to 40%. We've not been presenting in the dissemination here, but we've had all this data in the background before. So that is the all methods contraceptive prevalence rate for all women, 40%, and 34% for modern methods of family planning. So, breaking this a little bit further down, we've seen, of course, the 34% for all for MCPR or modern. MCPR is modern contraceptive prevalence rate, and then the 5.9 for traditional. Total together form your 40%. But we have a proportion of women, of all women, who in the survey, when we ask questions about whether they want to have a child soon, within the next 2 years, they say no to that question. But then when we ask if they are using anything to avoid getting pregnant, they say no. So those women, together with those who are currently pregnant, but when we ask if the last pregnancy they are carrying, the pregnancy they are carrying was intended, they tell us it was unintended. So if you have an unintended pregnancy currently that you're carrying, and all you are not using any, all you don't want to have a child within the next 2 years, but you're not using any method of family planning, those two combined together form what we call the unmet need. So this is technically computed on our side, but based on those questions and a series of qualifications for you to come to this. So 15.3% of all women in this country, 15 to 49, have an unmet need for family planning. If we use, and then, okay, let me first explain this. Then we have 44.8% who have fertility desires. They are intending to have a child within the next 2 years, or they are currently pregnant by choice. So some of the ones in the red are currently pregnant, but unintended. But the ones here in the 44.8, some are pregnant by choice, or they want to have a child within the next 2 years. So those ones have fertility desires. So we don't expect them to be using family planning. So if they are not using, it is okay. Because if they get a child, that child will not be, unintended, unwanted, because they are, within their window, very recent window. So, near future window, sorry. So those are fertility desires. They are still high. We don't want to put a number, a percentage to how many women should have fertility desires at any one point. But of course, when you have such a large number, it means we shouldn't be surprised that we are adding on 1.7, 1.8 million births a year, because we have so many women who are intending to have a child within the next 2 years. Now, some of them may have 1, 2, 3, 4 children. They are intending to have a 4th. Some of them may have 8. They are intending to have a 9th, willingly. So this is a matter of ideation, and Dr. Sekamate loves this ideation, I know. So if I want to take you through a little bit of the stages of change model, I think as implementing partners, we want to focus, the lowest hanging fruits are those who have an unmet need. If you focus on the stages of change, these have some sort of contemplation. Probably they are easy to attract to become users. There are these who have fertility desires. Some of them are pre-contemplators. I have 8 children, I'm focusing on the 9th, I have no problem with it. When you ask me, do you want to have a 9th child? I say yes, and I'm okay. So you're not going to drag me to using, but then the information you provide probably will move me from pre-contemplation to contemplation. So you can move women from the fertility desires to unmet need. That is probably the first stop. Some of them will jump directly to use. That is a winner if we do that. But that is hard. You probably move them to contemplation to think, maybe I should use, then focus on what should I use, where should I get it. And that's where we come in to give as much information as possible. Move them from pre-contemplation to contemplation, and then ultimately to action and and continuation of the behavior, which will be the MCPR. Of course, at any one point, we have to have women who want to have a child within the next 2 years. So we don't want to cut this down to 0. Of course, it doesn't happen. So that's, I think, one thing we can focus on as IPs, where the low-hanging fruits are. You don't want any red, but also you want to move more women, to MCPR. Now, the other indicator, sorry, the titles are hidden for people inside here, but I can remember them for you. These are trends in use of family planning or the methods of family planning for married women. The slide that we had before, this one, is focusing on all women. Now we go to the one that is focusing on married women specifically. So this is, and let me just focus on the current survey. These are trends, again, from 2018 to the current 2021, September to November. So the current contraceptive prevalence rate for all women is at 50%, 50.2%. Don't confuse this with the 50 that we had in the early CIP 1, because that was 50 for modern, right? This is 50 for all methods. So the modern is still at 42.7. We have not even hit our 2020 indicator yet, which was 50 for modern, for married women. So this is at 42.7%. 50 is the green, the biggest bar, and then the pink is 42.7, and then the lavender is 7.4, which is the traditional methods. So these traditional and combined with the modern form all methods contraceptive prevalence rate. And you can see the trends, as Dr. Olaro mentioned, we are moving upwards. Actually, this year we see a significant jump. What you see here are error bars or confidence intervals. So you can see that over time, we've had in some surveys, although we presented an indicator that was slightly higher than the year before, it wasn't significantly different. But today, we are presenting a figure that is significantly different from, for example, from 2019 onwards. So we've had a real, true increase. We had COVID, we've been in COVID. This survey has been conducted after a series of restrictions and lockdowns. But remember, you all partners and Ministry of Health, you had adaptations. Maybe the adaptations have worked. Dr. Olaro mentioned, should we need to focus on, I think Dr. Mugahi as well, we need to focus on what works. So what is it that has worked this time around? Those adaptations, maybe we need to take them forward. Maybe the services were hit, but maybe people were at home, and so they had the contemplation to think, I am home more. Maybe there's more frequent sex. So maybe they thought about use, which they did not have to think about before. So some of these could be our explanations. We don't know. We present this to you, but you have some thoughts behind the data if you want to discuss it. So this is what we probably think, that maybe that's the jump that we are seeing from 44.8 to 50.2 for all methods contraceptive prevalence rate for married women. And remember, in the morning, in the Dean's remarks, she mentioned that we don't want to leave anyone behind. And so we've had to break this down a little bit, but not too much, because we don't want to have so many, a slide congestion here. So we only focused on residence and education. Again, this is modern contraceptive. This one now is focusing on only modern among women in the rural and urban, and then those with different variations of education. And we see that the p-values you see up there, 0.034 on the residence, shows that there is a significant difference between the urban and the rural. So the urban women at 47.9% for modern methods among married women in the urban areas is different from 41.5 in the rural areas. So we still have equity issues between the urban and the rural, because ideally people should be on the same footing if we are focusing on the ideal world. But we see that there are challenges in the rural areas. Even the urban still have challenges. We have urban poor and all that who are bringing down that indicator, but we need to focus on them as well. For the education, we have some sort of dose response. The higher you go with education, the better. You can see that there are significant differences between those in secondary and then those in primary. So when you go to secondary and over, and the Dean mentioned about education, not forgetting education, it has an impact, and you can see the impact really. And you see that, higher dose response. The confidence intervals are wider at the top university and tertiary because we have a smaller sample size there. There are very few women in this country that have tertiary and university education, which is, of course, not a very good thing. Okay, so then we go to the breaking down. We call this the method mix. The method mix is we get all the women who are currently using a method, this time modern methods of family planning, and then we just distribute the methods around and see what are they using. So how is the distribution Okay, I think the ideal should have been equal, but it doesn't happen. That's the perfect world. So what we see is that injectables, and that is IM, I think that's green, where you see inject IM, that is intramuscular, DMPA, and then injectable SC, which is the subcutaneous, that is cyanopress. So those combined form about 40, so these ones are still the most used method. The injectables still dominate our method mix for married women. And then we have the distribution we have the implants, which are rising. They have been rising fast over the last surveys. This year, actually, we didn't have a jump, that much for implants, but they remained, steadily up there as the second most used method. And then we know that the long-acting methods are more effective. So we want to probably, have many more women move to that level. And then maybe here what you see is that the IUD has not been growing. The IUD has not been growing. It is stagnant over the last about, I think, 4 surveys. We've been seeing, we had, I think, 3 at some point, then moved to 4, then 5, then we've been stagnating at 5, I think, last 2 surveys. So we don't know what's going on there, and we know how effective the IUD is. So maybe something to think about there. Okay, then quickly, about to complete my part, these are trends in demand, total demand, and demand satisfied. Again, this is focusing on married women, and you can focus on the gold part there, which is the last survey, the current survey, September to November 2021, the different colored one. And what we have as total demand is the combination of those who have an unmet need plus those who have a met need. The met need is those who are using a method of family planning. So you have 20.9 in the last column, plus 50.2, which give you 71.1. That is our total demand. I think you can see over time that the total demand is not increasing very well from the last survey. It has increased a bit, but probably not rising very fast. But when it rises, we need to keep it rising with methods of family planning, not unmet need, because it could also rise, but it could be a contribution of unmet need. Luckily, we see that unmet need is dropping, and you see it has dropped from 23.8 from the last survey, from 2020 to the current 20.9. So we're doing something, at least I think as IPs, you're doing something, and Ministry of Health. And what is of that demand, the 71%? What demand is satisfied by modern methods? So the demand satisfied by modern methods is basically the modern contraceptive prevalence rate, which is 42.7, the second last row, and in the last column, 42.7 divided by 71.1, that will give you about 60%. So 60% of our demand is satisfied by modern methods. One thing you need to note here is the demand that is satisfied by modern methods has actually moved from 54 to 60%. And I think wonderful. It means the MCPR has actually improved, and that's what we saw. So we are doing, at least we are getting somewhere to that level, but we want this to be, of course, much higher than that. And then, now I dive into the quality. And this is a nagging indicator, ladies and gentlemen, over time. The quality of services is still wanting, even before I present the results, and you can see it already. So this is what we call the Method Information Index Plus. It's a combination of 4 questions. One of the questions is we ask among those who are current users. Now, these are women we have won over already. So we have them. They are converted. They are using. But what are we giving them? What you give me when you have won me over determines whether I stay or I leave. It determines whether I bring somebody else or I don't. If you are served badly in a restaurant, I don't think you recommend it. If you're served well, you keep going back, but you may go back with a friend. So how about we look at family planning service like this? This is the quality we are providing. So these are the 4 questions. Women who are told about side effects among current users, we asked them, the last time you obtained this method you're using, were you told about side effects? Were you told, if you are told about side effects, were you told what to do about those side effects in case they happened? Were you told about availability of other methods other than the one that you've taken? Were you told about the possibility of switching if the method is switchable, or if it's permanent, were you told also about that? So we see that only 43.8% of women who are currently using a method of family planning were actually told about all the 4 questions. Only 43.8. Last year we had about 42 0.2, I think. It's not rising, really. This is a stagnating indicator. We want this to be up there 100%. And you see that the problem is cutting across equity issues, leaving no one behind. Everyone is behind this time around, okay? You can see urban and rural, same problems. Age groups, maybe adolescents are worse off, but also, common problems even among older women. So we are breaking this down just for you to see. If you are Minister of Health, if you are an implementing partner, any one of us, all of us here, where are we doing worst? Because when we combine the indicator, we combine an index combines all the 4 questions. Now we want to break it down. Maybe we are doing well on some of them. We're actually doing bad everywhere. But we're doing worse where it matters the most, side effects. Women are not being told about the potential side effects of the method. They are not being told what to do in case they experience those side effects. We don't have the results, we don't present the results today here, but we have the data which shows among the non-users now, when you ask them, why are you not using a method? Fear of side effects, method-related concerns. Then you go to the users and you ask them, were you told about side effects? No. So if I wasn't told about side effects, I experience them, I go to my friend is not a user, she fears side effects. I wasn't told, I've experienced them, what am I going to tell her? So am I a change agent? No. So I think we need to focus on that and make sure everyone is told about potential side effects and what to do in case they experience those side effects. And that is a challenge. And usually I tell this because we get calls from the field, because our numbers and the consent forms on the surveys. But interestingly, many of the phone calls we get are not from women who participate in the survey, but from their friends who are looking for support. And last week, I think Prof. Makum, it was last week, we got a call from Bulisa. Of course, sometimes people call you and I'm struggling with language and I look for somebody who speaks the language. You don't have anyone. Then can you speak some English? Then we speak. And then she told me, I stopped using the injectable in December. That's when it was supposed to expire, I think December 12th. She called and she said, I have not seen my menses. I have not returned to my menses and I am worried. I don't know if I'm pregnant or not, but I stopped using it to get what? To get pregnant. And now I'm worried. And she was at a facility somewhere in Bulisa. She wasn't, being attended to yet. She was, I think, in a line. But she called this number and they said, they told me you're one of the health workers. Unfortunately, when they see the consent form numbers, they think you're a health worker. So they call. And we thought with Prof. Makumbi, maybe we need to have a functional call centers that people can actually call into, and these numbers are publicized, and people really pick them, and they're toll free. Because this is somebody who was calling using an MTN line, calling my Airtel line. They are investing time and money into trying to get the quality that they need. So she's not aware that maybe these are delayed measures and it's normal, because they were not told when they were receiving the method. So this is where we need to do quite some work. So I want to stop it here and then hand over to Professor Makumbi to take you through the next part of the presentation. Thank you so much for listening.
Yes, so thank you very much, Simon. I wish this could go a bit lower so that I can be like you. But I hope I can hang in there. So I'm going to do the last part of this story. I hope I can maintain the narrative. But we have been touched by many stories coming from the communities. And actually one time somebody called me because they had got some side effects. I didn't know how to handle them suddenly. But I was able to engage our colleague, Sarah. She has a clinical nursing background. This was at night at 9. And this was a desperate woman in Ibu, in Eastern, Buked, something like that. I said, okay, we are putting our lives in line, but good enough, we don't fake. We are not medical doctors. We look for the clinical persons, and we only tell them, yes, we've got the information, let us take it, the talk, and appropriately handle this. Yeah, but these real life stories are not like, oh my goodness. So people are following up, and they are trying to look for help. But given those stories, there are issues of intentions to use, as Simon has indicated. Ideation, people with unmet need. When we go out, we ask women whether they intend to use contraceptive methods. This time around, we asked people, women, who are non-users at the time, whether they intend to use contraceptives in the next 12 months. Literature has shown, including what we have done, that actually intentions to use is a good predictor of who will subsequently use. So when we asked, for every 100 women we asked, only 20% said they intend to use. maybe we need to work around improving. If intention to use is a predictor, we may need to work around there and also address the issue of those who are in the fertility desires. Maybe they may want to change for as long as they have information. Mr. Mwonga, when he was here, he's indicated to you that we have changed the design of this, how we evaluate and generate evidence. And some of the things we have tried to do is we have been able to identify women in 2020, the last survey of 2020. We asked them how many intended to use modern contraceptives in the next year. And some of us told us they did not intend to use in the following year. So when we came back in 2021, those who say they intended to use in the future, 46% end up using modern method. Of those who say they did not intend to use, 1 year later, 20% had indicated. So intentions change and practice. So this means we need to work on those who say they intend to use and avail maybe services and also continue engaging them. Maybe shall move from 46% to maybe 90%. There are barriers and challenges which do not make those who intended to use. But also free to withdraw and change and say this time around I don't want to use. So, but we should be able to tap into that. But what is also very striking, those who say they do not intend to use, 20% use subsequently 12 months. Which means if somebody says they don't intend to use, just don't give up. Continue engaging and availing appropriate messages, and they can change their views given the circumstances, as we may have seen during the COVID period. The other interesting piece that we have here, this is, so we also went ahead, this has been covered. Women with the most recent pregnancies, what proportion had unintended? We looked at women who had had their last birth recently or who are currently pregnant. Then you ask them, wow, how many of you intended to have these pregnancies? 46% of those who are currently pregnant or who had had a last recent birth in the past 5 years, 46% said we did not intend to have that pregnancy. In a quick way of summarizing this and communicating to my village person or somebody who is not very conversant with the numbers, I can say for every 2 women who are pregnant, 1 of them did not intend. That's not very small. And we went ahead and say, what does that mean? Of those, how many had actually wished to not ever have any child? And how many actually wished to have children, but not at the time they did? Of the 46%, we subtracted and found that 13% of them did not actually want to have children anymore. So for those 33% who wanted to have children later on, you may say, okay, mistimed, whatever you want to call it, but the 13% who did not have any more, they had an additional family member. What is happening out there in order to look at the quality of care for the 13%? But what is also very striking, I'm a teacher and I'm good at pointing. The first batch is for, when you look at the 15, when you look at the 15 to 19-year-olds, there's no difference in unintended pregnancies between the rural and urban. The pink and the purple have the same level almost. So they think of saying, oh, the problem is the urban only, rather rural. No, we need to also work on the rural and the urban together. Are those being affected by the urban poor? We don't know. So more research we need to dig in and understand. But of course, this biggest problem between rural and urban, the difference in terms of unintended pregnancy is more common in the green one, the rural, when you look at the older women, 35 years and above. All these are lessons we need to think, the strategies. It's not a one-size-fits every age. We need to know which ages we are dealing with. Recently, I think the past 2-3 years, we have been working with Ministry of Health is leading the National Self-Care Guidelines. That's a big approach of seeing how can we enhance family planning services, and then that will roll into other services. So there's a component that focused on DMPA sub-Q or injectable sub-Q. Remember they had injectable IM and sub-Q and self-injection. So I'm going to present data which may provide us with a clear understanding of how self-care through self-injection with a focus on DMPA sub-Q or injectable. I don't want to put DMPA in full. I may end up biting my tongue, but so we went ahead working together with CIF, Children Investment Fund, which contributed to this survey because there was, I think, Mr. Mwonge or Dr. Mugahi who indicated, can we put other non-family planning modules in here? Yes, we have done something similar, right? Schistosomiasis, we have worked on that before, and many others are tapping into this platform to do this. So for the CIF, the Children Investment Fund went ahead and made significant contribution, financial, but also these questions on DMPA, self-injection, and their preferences. Of course, that's what we shall focus on, but also questions on HIV self-testing, as well as adding the 19 enumeration areas. So we quickly walk through, as we come towards the end, we shall quickly walk through the trends and patterns of injectable sub-Q use among women in Uganda, see the levels, but also look at the preferences, and also look at the site, the supply characteristics of these important commodities. So as a background, DMPA or injectable sub-Q have been increasing. In 2017, from only 2.1 to 7.8, almost nearly 4 times in a spell of 5 years. I should say we are doing very well, but I know as IPs, there's a potential to spread out, and the purpose of this sub-Q, as we shall see, is intended to create what we call self-injection, self-care ultimately, and that may break barriers. It's not for the sake of it. It may break barriers of access. We asked women, we had 244 who actually were users of injectable DMPA sub-Q, and we asked them where they obtained this method. Majority are from the public facilities, 60%. Those are most commonly spread out, and about 40%. And the details of which specific public or private are indicated, but 60% majority are public facilities. But also we went ahead to ask, of those 244, how many of you did the self-injection? Was it you or the provider? Only 2.4% cited in this last survey of 2020, as we saw in 2020, it was 2.4. But when we came in 2021, self-injection had increased to 3.6, nearly had doubled. So people doing self-injection is improving. So we need to create more awareness. We need to make sure the training has been done. We need to avail everything. Then women can take these commodities in their homes, and at the appropriate time, they don't need to worry about transport. They don't need to worry about men stopping them from going to health facility to get an injection. They can do it themselves. I know many of us who have non-communicables diseases, diabetes and the rest, we do self-injection. So why can't such a thing also be applicable in the area of family planning, where actually some people like men stop their spouses? But also we said, okay, now this is very important. What is the knowledge issue like around? So we asked women whether they have ever heard about a type of injection that one can inject by themselves. Now this was being asked for all the women. And about only 30% said, yes, we have ever heard about that. Then for those who have ever heard about the self-injection, we asked them whether they know the source where they can obtain. Only 3/4 knew. So if somebody knows that they have ever heard about it, you'd think we should have more information to know even where to get it. So we have a bit of work to create awareness about the source. Knowing is not enough, but also knowing where you are going to get it will be very important. So we need to enhance. 77% is high, but certain things need to be really universal, 100%. So then we went ahead and asked women non-users, those who intend to use in the future, do you intend, you're a non-user now of family planning, do you intend to use in the future an injection? And what percent is preferring self-injection? What percent prefers somebody else to do the injection? So 14% of the current non-users who intend to use injections in the future, 14% said, I want to do it myself. So there's a window of opportunity here we can tap into and start breaking the barriers, because women are willing. But even those who want health providers, mind you, these are non-users of any family planning method, we can easily dig into this and tap into this and break the barriers and enhance uptake of family planning. So, but then we ask ourselves, who would be a quicker user or a likely user of injecting, self-injection? Is it those who are using any method now, or those who are not using any method now? What we discover that when you look at any family planning users, 41% says, I'm willing to do self-injection. However, those who are non-users, 22% are saying, well, it is still high, because if you're not a non-user, and now you are still also willing to do self-injection, then that is going to be very important. So the window of opportunity is available. We need to start tapping into this, and we stop talking about it and act really. And I would never discriminate between the user and non-user, because these are very interesting statistics, creating opportunities. Delivery, as I move towards the end of this, so we can have sufficient time for discussion, what is happening at the service delivery points which have got commodities? We went 255 public and 118 in the private. And Simon expounded on this, how we go there and how we select them. One of the challenges we always focus on as what we want, because we want to improve service delivery, the dark color there shows current stock among in the public facility. The IUD stock stood at 66%. And about 8% were either stocked out at the time of the survey or in the previous 3 months. What about implants? Implants, 21% were stocked out in the past 3 months. And in 90%, I'm looking at the extreme bar, and 9% were stocked out at the time of our survey, making it 30%. So implant stockouts were very common compared to the IUDs, which had lower use, as we have seen. But also went ahead and said, what can we look at injectables? Again, public facilities. Part of the reason for public facilities, there are many, and so you can get stable statistics instead of dealing with 1 or 2 facilities. The last column again, 71% in the last survey of 2021, 71% of the facilities were stocked, but 18% were currently out of injectables. And again, whenever I receive a call or Simon, we discuss. We had a case from Nakanyonyi, Sekanyonyi in the Mitiana area, and this is a non-study participant, but through another colleague got our phone numbers and called and said, well, I've been this place, I've been asked to, I have come for injectables for the past 2 months, but I'm not getting them. What can I do? Poor researchers. We again engage the MOH persons that we have quick access to and tell them the stories, and then they direct us to the potential implementing partners. That's the best we can do, but I think these are real life stories. Interestingly, they are not from our respondents, but they are colleagues or friends of the respondents. So the networking is really working out there. What about oral contraceptive pills stockouts? I dare say nearly half of the facilities we are stocked out either at the time of the survey or in the past 3 months. What are the reasons that are underlying the stockouts? We have been able to make again our inquiries, and we have discovered that a lot of it is supply related. 45%, quite 44.6% of the facilities said they ordered, but they did not receive shipment. And 20%, this is the orange, dark orange, they ordered but not received the right quantities. But again, let us not also miss the 9.6%, which said unexpected increased consumption. Very beautiful. So yes, there's a need to plan and quantify correctly, but for as long as implementing partners, Ministry of Health and others are mobilizing and creating awareness, people are coming and using, and facilities discover don't have enough. But I have also heard there's been redistribution mechanisms. Are they working very well? I think that needs to be discussed and see how well we can address that. And in my kind of winding up, we also looked at, if you are going to provide quality service, the issue of training is one of those things you need to put at the back, beyond the stocks. So for DMPA, or injectable sub-Q, we went ahead and inquired from facilities that are offering DMPA sub-Q and asked them whether they offer self-injection training for DMPA sub-Q. Only a quarter, basically 1 in 4, said yes, you're offering the training. You offer the service, DMPA sub-Q, but then the training, you don't seem to be, only 1 in 4 do. And then for those who offer it, the training, we asked whether they have offered in the past 4 weeks. The recency, it is less than half, about 47%. So I think we can have, we have opportunity to do better. And personally, I'm not discouraged you. I'm seeing a lot of opportunities and windows being opened for us to now move in on evidence-based. But so also we went ahead and asked about the issues of stock out of specifically DMPA or injectable sub-Q in these facilities, 281, and 64%, nearly 2/3 were stocked, but again about 30% were out of stock of this specific method. Having gone through all this, there could be a lot of summary or take-home message from here. We didn't want to leave this one blank, but also we wanted to provide our thoughts. On one hand, you may have your thoughts and they'll be extremely important. What do you take from all this data? So one thing is so clear, we are seeing increasing modern contraceptive use. Very important, but also don't forget the traditional is also increasing, and we have found it to be more common among women in wealthier quintiles, the traditional. And of course, DMP or injectables are still dominating, and we have seen about 14% of non-users in the future, they would prefer self-injection. So that is very critical and important. Facilitated desires, you saw 44 or 45%, that white pie chart that Simon shared, of women who desire to have children within the next 2 years or who are currently pregnant. High fertility temptations. We don't want to say high because we don't know what low is. But is that high? Is it low? Are we doing enough providing what should be provided so that we can create animate need and then address it? Again, that's for discussion. And we also realize that only 1 in 5 women said of non-users, they had intention to future use. So we need to go ahead and break into that as well. Are we not providing sufficient information for them to move into the ideation stages, create and give them opportunity so that nobody may be left behind? And for facilities, definitely we are seeing the lack of long-acting reversible implant and IUDs been increasing, especially implant. Reasons for stock out has been shown, and we kind of have a sense of why the stock out issues are because of delivery issues. Again, we need to again discuss that, and I understand the loss of dynamics going on and to try and address that issue. And of course, the quality of services as indicated through the information index low. Only 43% have all the 4 side effects being told, didn't know what to do, other options. Only 4 out of 10 actually have that information. So given that, I think this can help us form a nice discussion. I know we don't have sufficient time. We can continue engaging through these channels. But also it's okay, I think, to organize small meetings. We are usually part of the technical working group for family planning, but also we can engage other partners, different fora, to discuss this, because we have done that, and it has been very helpful because it has informed their programming subsequently. We don't want to leave it here, but I think every one of us has an opportunity to play their role. We generate evidence, we work with the Ministry of Health, implementing partners, population council, and everybody. So every one of us, the policy people, the program people, the data generators, so that we can have evidence-informed decisions, and I can bet you me that can make a significant difference. And I'm glad to see our members of parliament who can help and support when all this information gets to parliament, and say we need more funding if that's what we need. So thank you very much for listening, and I guess you can step into the next chair. Over to you.
Another big round of applause for our presenters. They've done a great job. I received a request by our honorable members of parliament. They're excusing themselves to go for another important meeting, an update about the Public Health Act. So we might be remain with a few of them, but some of them have left. Let's now have a presentation from Dr. Betty, and that marks the end of the presentations, and then we discuss at once. This is a meeting that's supposed to end at 10:30, and I'll end it at exactly that. Dr. Betty, you're welcome. Join me in welcoming her, and she will spare us some minutes.
Thank you very much, Chair, Dr. Mugahi, the honorable members of parliament who are still with us, the chair of the technical advisory group, who is my boss, Dr. Jotham Musinguzi, colleagues, ladies and gentlemen. I was requested to make a summary of a presentation, but I'm not going to make a summary because I'm sure all the people in the room are able to listen in and pick issues as they have been presented. Actually, on my table, the team that is sitting there was very excited about the results that have been presented today. So I'm going to make a more contextual inroad into what has been presented and what are we supposed to do as the different people sitting around the table. What will be our role in ensuring that the evidence that has been presented to us today is put to action? So number one, there is no doubt we're seeing an increasing uptake of family planning services. Both modern contraceptive prevalence rates and the total modern contraceptive prevalence rate have been shown to be increasing. And I think we need to give ourselves a big hand clap for such a huge achievement as a country. But nonetheless, there's more need to transform this potential family planning use into what we want to see. Yes, we are seeing increasing uptake of family planning services, but what do we want to see the increasing use of family planning services for? Are we seeing it making a contribution to reducing fertility? That is question one. If we are to receive results, for example, of a demographic and health survey Mr. Mwonge has worked out, what is our fertility rate going to be as Uganda? Are we going to see more reduced child mortality? Are we going to see improvement in the health of mothers in terms of reducing maternal mortality ratio? Are we going to see an increase in terms of the investments that we are making in improving and transforming the socioeconomic aspects of our country? So these are the questions that we need to speak about. But even as we see the increase in family planning services, is it showing us an increase in the support for the people who want the family planning services to receive the service? So are we seeing the political will and commitment for family planning increasing at all levels? At national level, today we have had representation of our members of parliament. And for those that have engaged and consistently work with them, they are committed to the family planning agenda of this country. But how committed are the leaders in the districts, in the local governments? We now have cities, we have municipalities. What is the level of commitment? And I think next time, Professor, we need to invite districts, or are they here, so that they tell us what is happening, because with the development of our first family planning costed implementation plan, we agreed that we are going to domesticate the national FPCIP at districts. Dr. Mugahi must be smiling because he keeps asking us, what have we done as the National Population Council to make sure that all districts or all local governments have their family planning costed implementation plans? So ladies and gentlemen, I think these are some of the questions that come out of this presentation. So even as we think about generating data and using data for informed decisions, are we seeing data that is coming from the HMIS, from the DHIS2, being used to inform decisions about the planning aspects within the districts? To what extent are we integrating, for example, the issues of DMPS sub-Q in HMIS? And I think this has been a question that is grappling Dr. Olaro. Even when we have the meetings on DMPS sub-Q, we are still grappling with ensuring that DMPS sub-Q self-care, self-injection is integrated in the HMIS. But we are also looking at how are we going to convince and work with pharmacies to integrate DMPS sub-Q at pharmacy level. Because we know that it is easier for me to go to a drug shop or a pharmacy and pick any type of commodity, whether it is for treatment of malaria or whether it is for family planning. It is easier to do that than to go to a health facility. So that is the other question that we pick from this presentation. Then in terms of there are issues that have been pointed out, which we must focus on. The use of contraceptives by certain groups such as adolescents and men. These have been largely overlooked, and in this presentation we have seen use by young people. Even when it comes to what they call the counseling, the information, I haven't yet picked that language very fast, but you all heard what it is. In terms of counseling, it is the adolescents that don't get adequate counseling when they need the services. But we are seeing an increasing number of teenage pregnancy rates. And if we are not going to work with these young people, I'm sure Dr. Msinguzi is going to come and give us a presentation on our development perspectives as a country and why we must focus on improving family planning use among adolescents. It is something that we fear speaking about. It is actually something that we are fearing to implement, but I think it is high time we really focused on ensuring that our adolescents who are sexually active access and use family planning services. Then the other issue that has come out is about the distribution of contraceptives beyond the health facilities. We know, and I have alluded to this already, where are our family planning service delivery points? We know and we appreciate the role that different implementing partners play in improving family planning services by ensuring that we have outreaches, we have services received and distributed at different levels. But I think we need to do more and work more with the community health workers and VHTs, especially if we are going to increase family planning services. But even as we do that, remember this meeting is about evidence generation. Are we going to be smart enough to ensure that what the services that are provided outside the service, the traditional service delivery points, the health facilities, we have that data integrated within the HMIS, because I think we usually have gaps at that level. So the other point that comes out for me is on expansion of types of contraceptives, including the sterilization. The chair has told us we were informed that is a champion of vasectomy. I knew one champion of vasectomy. This morning I have learnt a number of vasectomy champions, and this is very great news, I think, for us. If we have more of these champions and they convince more of the men in communities about the benefits of family planning, I think we shall have done a great job for this country. So increasing and expanding the types of contraceptives is very, very vital for us. But also the role of a private sector, including the commercial sector, to provide services and facilitate local and private initiatives. And also the collaborations with the private sector are very key in improving efficiency. So we cannot overlook the private sector in terms of expanding our family planning program. And also the family planning program effectiveness hinges on large-scale efforts that can be sustained over a long period of time with strong leadership and commitment in terms of finances and technical support. I have already talked about the commitment that we are receiving at national level, but are the finances enough? And we have also seen some of our challenges are, one, in this presentation, we have seen last mile delivery. Because yes, commodities, we have better stocks at the facilities now, but some of the reasons why there are stocks, it is because what we requested for, or what we ordered, is not what was sent, or what we ordered has not yet been delivered. So we still have challenges with the last mile delivery. And I fear, looking at my boss, National Medical Stores, I think still has a little more work to do in this particular area, but with support of all of us. So, but also within the local governments, how have we prioritized family planning? The partners that have supported the development of district family planning costed implementation plans usually start by constituting a group of leaders, multi-sectoral working group, to bring forth the discussion on family planning, even before they finalize the district family planning costed implementation plans. But after the plan has been developed, what happens? Is it financially supported? Is there room for coordination? Is there room for ensuring accountability? So if we can do some of these things right, ladies and gentlemen, I think we are soon going to see the MCPR even beyond what we have put as our target. And as I conclude, I also just want to make a few points in relation to the programs that we already have in terms of improving family planning. One, the third National Development Plan has given us 2 major programs that will help us improve family planning service delivery and family planning, the agenda for this country. One, the Human Capital Development Program. So when we are presenting and disseminating some of these findings, we need to invite the Human Capital Development Program partners to this meeting. Ministry of Health is very well represented. Is Ministry of Education and Sports in the meeting? Is Ministry of Gender, Labor and Social Development here? Is Ministry of Local Government here? Because we continuously speak to ourselves, and yet we know we have a challenge of making sure that family planning should be implemented in a multi-sectoral approach. Then we also have a community mobilization and mindset program, which is very key because we continue seeing myths and misconceptions. When the media reports on family planning, we usually pick the negative aspects about the family planning program. We don't mainly see the benefits. So there is room for us to continue engaging with some of these programs. And lastly, we also have a parish development model. I'm not yet an expert, and I don't have so much to speak about the parish development model for improving family planning. But I usually want to hear voices of representatives from the local governments, how they feel this is going to help us. Because two of the pillars of this parish development model, one is increasing service delivery, but also two, ensuring that we have a mindset change. And we have negative perceptions about family planning. And I think it is high time that we engage strongly to change the mindset on family planning, but also improve family planning through ensuring the service is delivered. Lastly, ladies and gentlemen, in the presentation, issues about promoting technology came out strongly. And I think we cannot run away from integrating technology into our family planning agenda. So with this, ladies and gentlemen, allow me hand back to the chairperson, and thank you so much for listening to me.
Thank you so much. Thank you, Dr. Betty Chadondo, and for opening the platform. Now it's time for our discussions, and I'll be supported by Ms. Harriet Adong. First of all, we have an online audience, and I think Melody, will you help us summarize the online comments? Because of the time we have here, I would encourage the online participants. I'll pick some few hands there, but I would encourage our online participants to put their questions on the chat group, and we pick them up. We should be able to appropriate them to the respective speakers. And then from the House, how do we find out if they are online hands?
So we have some comments,
Okay.
Chair.
No hands, okay.
Yeah, and we have some questions online. Maybe we start off with online.
I could invite the presenters to step forward. Simon and you're comfortable there? Academicians, they hate high table. You come. Professors fear high table. I don't know why. No, it's part of recognition for the great work you did.
So Chair, how do we do this? We go with the online, a few questions
Yes,
online,
please,
and
please
then
do.
we'll come back to the physical audience. Okay, so online, we have quite a lot of questions. So I'll just read through the first 6, and then maybe we give a chance to our principal investigators to respond. Question 1, thanks for the data. Regarding the quality of services, I do appreciate the gap in health education, stroke family planning counseling. But how have you accounted for recall bias from the respondents? Number 2, 40% of current users are not told about family planning side effects. Does this differ from family planning methods? Are some women more likely not to be told about side effects than others? Finally, this presents a missed opportunity to inform women about side effects so they can make informed decisions. Question: what strategies are in place to reduce the proportion of women who are not told about side effects? The other question, if I'm first, please signal to me. If the SDPs where the respondents accessed the contraceptive methods are disaggregated by facility versus community distribution mechanisms, will the findings about the quality of counseling be different? If the SDPs where the respondents accessed the contraceptive methods are disaggregated by facility versus community distribution mechanisms, will the findings about the quality of counseling be different? Should I give you another? Okay. The other question is, It would be great to break down this data by regions. Is this possible? The other is, what percentage of women using DMPA-SC were adolescents? That is 15 to 19 years of age. The other, what channels of information on DMPA-SC were most effective? I guess you will stop me. And then the other question is, how did self-injection use differ across age groups? Okay. The other is, we are still having family planning commodity stockouts in 2022. What is the interim plan to fast track this gap before we lose our gains? Okay. Then the other is, 79% of non-users did not intend to use contraception in the next 12 months. What implications do these findings have on demand creation for contraception among potential users? I think I can do the 3 more and then hand over to you. It is ironic that despite COVID-19 and the restrictions put in place, the data is much more encouraging than expected. Please disaggregate adolescent-related data, especially in rural urban areas. And then the second last for now is, provide the percentage of facilities offering family planning services vis-a-vis the non-providers disaggregated by region. Facilities offering family planning vis-a-vis the non-providers, and this should be disaggregated by region. And then the last for this round is, what accounts for poor uptake in institutions, even below primary and secondary school use? What is the age profile of this cohort? Chair, I hand over to the principal investigators. Thank you.
Thank you so much. I think there have been a couple of questions really. And some are really to the presenters, others are to the programmers in the house. But I would like our presenters to focus on what really belongs to them. Then the rest we shall attempt to also respond. Thank you. Yeah, that could be fine. And some of them actually might be. I think that's good guidance. Good guidance from Dr. Charles. We get also the questions from, okay. And also feel free to write down your question. Feel free. We may not have enough time for everyone to ask their questions, but feel free to write your question and forward it to the front desk here. Thank you, Dr. Charles.
I want to thank the principal and the co-investigators. I did observe when we did disaggregated by education that there was a drop at tertiary. I was trying to wonder, I thought as education improves, goes up, actually uptake also goes up. So I was just trying to understand what was the challenge in that. Probably we might need to understand what's the challenge in that strata. The other aspect which I wanted to make, it might not necessarily be a question, it was an aspect of observation, is that currently we don't have a product for the private sector for the self-injection. And I'm sure if we had, then it would drive. So I think this is where we need to work on and be able to see that we introduce a product for the private sector, and then you will probably be able to see how self-injection will skyrocket. those are my two comments.
Yeah, thank you, Chair, and thank you, the presenters. Mine is the issue of the use of IUDs. How can we improve? Because there is an issue where women fear side effects. When you get some information from women when they are discussing in the saloons and what, when you talk among them, when they talk among themselves, they say, how can I put it? I'm not sure about the behavior of my husband. That's sometimes the reason they give. Fear of STIs. Sorry.
Thank you very much to the presenters. I really thank you for this eye-opening presentation. Mine are two comments. One, on behalf of my neighbor who's leaving, a thank you to the 1.1% of men who help to inject their partner. I think that is really, really commendable. And if we keep encouraging these people, I think it's really a great way to involve the men in the women's health. Now, I want to comment on the social determinants of health. And I'm linking this to what we saw in the presentation and what Dr. Mihayo is talking about, the low uptake of IUDs. Last week I was in Rakai and I had informal discussions with a group of women who had come to get their family planning method. And they all seemed to know what they wanted. They knew, I want an injection, I want this. So I just engaged them and asked them why do you want this and not that? Do you know about the others? And out of 6 women I spoke to, 4 of them told me they had used an IUD. They had a bad infection. The IUD was removed. And of the 4, 3 said they would never use it again. So I thought of, what else beyond health? I thought of water and environment, sanitation, I thought of education. All these things were running in my mind. And those now are missed opportunities. So linking that to the discussion we are having here, I'm so happy that Dr. Betty talked about the Human Capital Development Program, because it gives us an opportunity to bring the different sectors on the table. And it is something we as stakeholders need to adapt to, take it forward, involve other sectors, speak with them, let them give us their ideas, and that way we will come up with some solutions that are outside of the norm that we've been practicing over time. Thank you.
Thank you, Dr. Rita. We shall take 5 questions, and as I mentioned, we are going to encourage the rest of us to write down our comments. Yes, take that question, please. Harriet, it's okay.
Thank you so much, Fiona Lugembe from Perth. Thank you so much for the presentation. Dr. Laro talked about the private sector commodity for DMPSC. I'm just giving information that around 2024, we are likely to have this product. This is work in progress. But also to emphasize the issue of quality counseling as a recommendation, in addition to Dr. Betty's comments, and also demand creation. And in this case, not just talk about it, but for instance, the Ministry of Health, how can we track who is doing quality counseling? Because we've talked about this over and over. For instance, we know that now we are doing the ready, but you'll find other people still doing the gather. So I know you've talked so much about it, but what more can we do? Thank you so much.
Anyone here?
And we'd like to stop at that now and probably provide the answers. I don't know if they're the answers, but
Thank you, Professor Frederick and Simon and all the other speakers who spoke earlier. Mine is to do with the method information index, and in particular the issue of the side effects, but speaking about the issue of return to fertility as a key issue. It seems that it is a key issue, but it's coming out in this study, but also in another DMPSC study that I've personally been an investigator for. And it doesn't seem to be as such a side effect. It's more of a misconception, but also an entrenched norm that fertility return to it is a very important issue to women. And so sometimes they delay the next method, and within that window, they get pregnant, even with the most popular method, the injectables. So probably it needs some further study, some further understanding and intervention. Thank you.
Thank you very much, Chair, and all members present and on vacuum. I want to comment on Dr. Betty's presentation, where she said that if the uptake is really to improve, we have to use the grassroots health workers, that is the VHTs plus other grassroots health workers in those very sub-counties and villages and the parishes. This practically improves family planning uptake, because I can take an example. When FHI was having the program of community family planning using VHTs, thanks to FHI, Frederick and Chris, by that time I was in Kamwenge, and that program empirically increased family planning services in the district. And the system was very clear in that the information could be captured and taken into the database of the district. We would not lose any data. So I would think that it is a very good practice for all partners who are in this room. VHTs are very important people, and they are very committed to their work. They can even be more committed than trained health workers, by the way, when you train them, and they know what they are doing. So if we are to improve on the family planning services, more partners should think along that lane. Then something on parish development model, how it is likely to impact on family planning uptake. You see, when you are trying to move the agenda of family planning in communities out there, most women are worried about, they are worried on their income levels. And they are like, when we are doing hard work and we are using some family planning methods, we get a lot of side effects. We get dizziness, we get excessive bleeding. Of course, most of them are what? Are myth. But like we said, parish development model is going to work on mindset. First of all, when these people are having their meetings on how to use these funds at parish level, so health workers can always be there. First of all, most of the partners that are providing family planning and the government itself had not worked on the other social determinants of health, like livelihoods. But now that this money is going to come to parish level, health workers can always integrate in their services, as they are also telling them to do what? To utilize family planning, now that they even have something to improve on their sources of income. And their mindset will change, and also the uptake will go up. I thank you.
I now invite my presenters to respond to some of the questions, and MOS will also respond to some. Thank you so much, Professor.
Okay, sure. So thank you very much for all the questions and comments and suggestions. Some of the questions actually are for all of us, meant to help us dig into the data a little bit more. We never prepared it that way. Thank you very much, Dr. Laro. The education component of the tertiary education, the numbers are small and noisy, but also we've been grappling with the way of making sure who is a tertiary in our data, because if somebody finishes S4, goes and does a course, technically speaking, we call them tertiary, which is understood to be post, maybe even secondary. Yeah, so we are trying to refine tuning our tools so that we can better understand them, but also we are messed up with the numbers. That's why you saw those, what we call error bars very tall, but we shall certainly work on that a little more. Then the other thing quickly, somebody asked about a question from the internet about the recall biases of the Method Information Index. Yes, surveys always have recall biases, but on the other hand, you keep asking yourself, why do you believe this indicator and not the other indicator? And but out of that, also on the other hand, you go ahead and step and say we've taken precautions in terms of training, but also most importantly, we have recently included the client exit interviews, which may help us possibly capture more recent, basically recent information about this. But that's the dilemma we face usually in most of the surveys. The best thing to do, train, supervise. We, Dr. B talked about this, and for the sake of everybody else, we have been working with Ministry of Health, National Population Council, and a number of partners conducting what we call regional disseminations. We've been able to go to about 5 regions, and with implementing partners. Dr. Mihai, I know we used to travel with him, and many others. Dr. Mugai, we are with you recently, Dr. Bechadon and the rest, and we want to continue doing that because we want to go. This has been national level. The DHOs are not here, and many partners aren't here, but we usually go with the partners working in that region and say, this the results, can we discuss and hear what's going on here? Of course, the statistics, we shall break them down, but the challenge again is that we don't have usually sufficient numbers when it go lower, but again, you're able to live within the available information and share it with, and we shall continue doing that. I hope partners are going to be fully available so that we can go together. I don't know if COVID, things have been improving. This goes back apparently to what again was said. I have been able to be part of the team looking at the HMIS data. The most greatest effect of COVID was in 2020 in the month of April. Thanks to government, Ministry of Health, and many key players, by June, a lot of things had improved, really, because of the strategy that we are put in place. And I think somebody made a comment, can we not continue look at those, how well they work, and maybe enhance them more? Maybe the result of what we are seeing. Yes, so I think we need to make sure we enhance what we did previously. I have decided to leave the harder ones to my colleague, Simon, to address them. But Dr. Rita, I was impressed with the 1.1 also, whereby men supported their partners in injecting. So this injection thing, don't leave men behind, even as we promote for those implement partners who are involved in this. Thank you very much. I hope I've been able to reasonably address some of the issues and concerns.
Thank you so much, Professor. He has summarized all the things. And I just wanted to add that this is not going to be the end. It's the beginning of the discussion, the synthesis. The professors have provided us the information. We are going to dissect it. We are going to be dissecting it. I was privileged to attend one of the regional meetings in Hoima last year. So I think we shall also have regional disseminations. So the question about dissemination and desegregation at regional level has been well answered, and we shall be able to tease out the regional specific drivers and where maybe why tradition is going up. So for MOH, I just want to summarize that there was an issue about private sector engagement. We have not done enough, but we are doing something. We also have the alternative distribution system. We are right now able to provide drugs, reproductive health supplies to private health facilities as long as they are registered. They are recognized by the districts. There is a form that they fill, and it gets to the Ministry of Health so they can get these supplies from JMS, Alternative Distribution System. Together with Dr. Muwonge, who has moved out, we are promoting the self-injection. Dr. Laro, in line with your comment, we've not reached up to scale, but we are moving steadily. Most of the documentation and paperwork has been done. The pilot programs are doing well, and we intend to scale it up. I think this might be a magic bullet because we are seeing very high uptake of injectables. We are also seeing private sector doing a good job in terms of access. So this has the ingredients of being a magic bullet. Stockouts for some key commodities, this happened at some point last year. We are aware, and I think Betty has pushed it, Dr. Musinguzi, but I also have his hotline. I can engage him remotely, especially some of the key stocks that we really need at facilities, the injectables. The redistribution mechanism is one of our biggest asset in addressing stockouts, pseudo stockouts. And it has been working quite well in some districts, and we expect it to work better now that we have at least pickups, 2 pickups in every district. We expect it to work better. We only need to intensify that they need to do it very well. The COVID pickup, some people were criticizing. They're going to help here. Lastly, the quality of counseling. Quality of counseling is an issue, and I think we are going, I can't promise an answer. It has been recurrent. It is acute on chronic. It keeps coming up. So I have no automatic answer here, but I want to assure you that we are looking at it very closely. We have the National Family Planning Think Tank that digests some of these issues and look at them critically and what implementation lessons we learn from them. I had forgotten, we are introducing or we are already doing something called pharmacovigilance, specifically for FP. We are trying to pick on some of these side effects. The Department of Pharmacy at the Ministry of Health is leading in the pharmacovigilance for reproductive health commodities. So the issue of side effects is our area of concern and how its impact on utilization. So those were the comments that were directed to the Ministry of Health. We can always have more engagement about the same. And we think my colleagues here, the presenters, have also done a good job. A big round of applause to those who asked and those who responded. And allow me at this time move to the last item on the agenda. We are only slightly out of our time, and the last item on the agenda is inviting our very important guest who has been with us from the start. Someone you all know who has been well introduced. He is the chair of the PMA. You want to introduce? He is the chair of the PMA National Advisory Committee. Yeah, feel free. Feel free. Is also the chair of the board of the National Medical Stores. Of course, he sits on a number of international boards. He is a seasoned healthcare practitioner. He has been a lecturer to most of us. He's still lecturing us. And he has been a champion of the family planning programming, the population dynamics in this country. I cannot describe him enough, but join me in welcoming him to make the closing remarks. Dr. Joseph Musinguzi, you're most welcome.
Thank you, Dr. Mugahi, Richard Mugahi, who has also been the chair of this session. I think I have liberated my face by removing the mask. The honorable members of parliament still present, I think I recognize one, but there could be others. The Dean of the School of Public Health, Professor Rhoda Wanyenza, I hope you are still with us virtually. Dr. Charles Sorara, who is the Director for Clinical Services, Minister of Health. The leadership of PMA, Professor Fred and your colleague Simon and others here present. The leadership of UBOS, partners in the field, religious leaders, the media, ladies and gentlemen, and those who are attending virtually. I know we are past our time for this, but I thought that what I really do is to thank all of you for being here all this time. We had a good contingent of members of parliament led by the
chairperson of the Committee of Health in the Parliament, and a number of others. And we want, when Honorable Sylvia, you go back to give them our thanks for supporting this process of the PMA. But I also asked that Dr. Charles Oraro stays on, because I have an important message which I wanted to deliver. That this morning I have seen that we are concentrating on family planning, but very little benefits of development are coming out. And I wanted us, since Parliament is here, but also the Minister of Health were represented with several implementing partners and development partners as well, to know that family planning is also a development issue. And I think Betty touched on this. I know she gave me instructions to, Betty dares to give me instructions what to say and what to say. But I also know that she wanted to speak about the demographic dividend concept. And she put it in a good way by talking about the parish development model. As you know, the Uganda is moving into this. We have a great opportunity, and I think I heard Rita and also the Honorable Sylvia talking about this, that we need to go down to the local level and engage our communities so that we can start making a difference. Family planning and reproductive health, Dr. Mugahi, Richard Mugahi, you know very well, you have worked the districts. This is a conveyor belt for making sure we deliver development for this country. I don't see they have removed my good slide. I wanted to, most of you know it, but I want to take advantage of the several members of Parliament here present. 3 weeks ago, I took a team of National Population Council to appear before the Budget Committee, the Finance Committee of Parliament, and we were able to talk to members of Parliament, show them the need for them to continue investing in the population and enrollment field, in reducing fertility of this country, both looking at issues that the Ministry of Health itself can be able to do, but also linking it with education, because education is also very important in reduction of fertility. So these are sectors, can it go on the screen? I don't need it myself, but it needs to go there. The idea is to really link these sectors in the context of the parish development model, which are going to impact on reduction of fertility and reducing it fairly rapidly so that the country can benefit from a demographic dividend. The demographic dividend is when you reduce fertility fast enough, not business as usual. If we do business as usual, Uganda will never be able to benefit from a demographic dividend. But we have an opportunity now that Fred and Simon have shown us that we can impact on contraceptive prevalence, we can push it fast. We need to make sure that education, health are working together so that the country moves from a pyramid that is very heavy at the bottom to a sort of pyramid, not exactly a pyramid, but there's a lot of people in the middle, and if these people get education, they get health, they have skills, then you have a huge population which can be the engine of growth, and I think of economic growth. And I think this is what we are talking about. Since about 10 years ago, 2012, 2013, Uganda has started witnessing the demographic transition process. Both fertility and mortality are coming down together. That is when a country enters the window of opportunity. And so I wanted to say that this is an important thing, and we need to continue linking reproductive health and family planning, and especially use of contraception, and making sure that our CPR goes up. And working with the Ministry of Health, working with the Ministry of Education and others, that is the way that we are going to make sure we do big impact on the education, on the health, and eventually the country exploiting its demographic dividend. With that, I think a lot of things have been talked about. Once again, I want to thank you for your participation and your keen interest. I think the country is at a point where if we continue to do things right, there is an opportunity that, as you can see from the family planning, there is some good things, some good news there. Challenges remain, but I think we're on the right track. And with that, it is my pleasure to officially declare this PMA dissemination, national dissemination and dialogue officially closed. Thank you all.
Okay, thank you so much. That brings us to a close. We would love to have a few group photos here with our principal investigators, our chair, just at the front here. Once again, thank you so much, all of you, for being a part of this. A big thank you to our online audience. Thank you for keeping with us up to now. Sorry. Honorable, come and join in the group picture. Yeah, we need some gender within this photo. Family planning is dominated by gentlemen, which is a good thing. Okay, so we are set for the group photo. Meantime, we are still thanking all our online audience. Thank you for being a part of this.